Hello. It is a very great pleasure for me to be with you today to share with you some of my thoughts and meanderings in the world of integrated care. Naomi, thank you very much for the invitation. So, my name is Anya Carroll, and you've seen my biog, and I've had an interesting career up to this point. I have started as a consultant in neurological rehabilitation in England and have been in the National Rehabilitation Hospital for about 17 years. But in that time, I've held a number of different leadership roles within the Irish healthcare system. First as clinical lead for the rehabilitation medicine programme, and then as national director. And now I'm in academia trying to answer some of the questions that I had when I was in the HSE. And I have to say, coming up with some of the answers, and I'm going to very happily share some of those findings with you today. So what am I going to talk to you about? I'm going to talk to you about spinal cord injury and integrated care. And usually when I start off, I like to ask people to think about, from your perspective, what do you think are health system challenges? And this is a topic that has been studied by a huge number of people, including the World Health Organization. And this slide is from my friend and colleague Nuria Toro's work in the World Health Organization. So when you look at this slide and you think about the Irish situation, I think that you would agree that a lot of these issues are as relevant to our situation, but actually this is our global perspective. So I think a lot of these issues are shared issues, and I firmly believe that the solutions to them will only be found by us all working together. I know we all like to think that we're very special, but at the end of the day, we're just all human beings trying to figure things out and make things better. So there's really two things: emerging demands and system constraints. So emerging demands, well, we know we have unhealthy behaviours and lifestyle choices. We know we have the issue of disease and multimorbidity, and the Irish figures show that that is not changing and indeed is getting worse, and that we're accumulating more morbidities as we age. There is the issue of greater citizen expectations and the increased need to self-manage care. There is a need for cost efficiency and accountability. And then in terms of system constraints, there's the lack of community engagement and empowerment. And I'm just 3/4 of the way through the North American Conference on Integrated Care. And that whole area of community engagement and empowerment, and that shift of power from the healthcare system to the community has really come out very, very powerfully as a huge requirement. There's also the issue of insufficient and misaligned financing. We have a suboptimal health workforce, and our services are fragmented with an inappropriate service delivery model. And we also have the issue, of course, of limited intersectoral action. And there's lots of different reasons for that, but those are just the realities of the situation. And really, we're so used to, especially in Ireland, so used to seeing these headlines. We've almost, I think, isn't there an expression about boiled frogs, that there's an expectation that as we head into another winter that we're already hearing about the waiting list being worse than ever. And isn't it extraordinary that we've grown tolerant of these headlines? But in particular, I'd like to draw your attention to this one. And now it's from last year, but it says more than 1 million people on hospital waiting lists, says consultant. And it wasn't the figure in itself that really attracted my attention. It was that I can't figure out why so many of us within this society are waiting for some kind of a procedure or surgery or outpatient waiting list. Surely we have to really start questioning why is that? And if you think about the need for us to, shift things to a much more preventative model from a population health point of view, where are we going wrong that so many of our citizens are actually requiring hospital-based services? So that screams to me of the need for us to fundamentally shift our mental model, if you like, of health and wellness completely on its head, and to really start thinking seriously outside the box. But it's not all doom and gloom, and I think it's really important for me to emphasise that a lot of work has been done, like much done, more to do. There's no doubt about that, and that the journey of 1,000 miles begins with one step, and that was really what the work of the Clinical Strategy and Programmes Division was really to pursue the quadruple aim. So better outcomes and improved patient experience, but with an improved clinician experience as well, at lower costs. And I think it's really important. So there's no dominant quadrant here, that we need to be simultaneously pursuing all four of these things. And there's no doubt that happy staff, happy patients, happy staff. You don't need multitude of literature to show you that that's the case. Now, there is loads of literature that says exactly that. But it just makes sense, doesn't it? It's just something that you kind of hear and you think, yeah, of course. But there's lots of literature to support that. So there are over 30 national clinical programmes, and I'm sure you'll be very aware of those clinical programmes. And in particular, of course, you'll be interested in the work of the Rehabilitation Medicine programme and the Neurology programme. And lots of interesting work in terms of policies and strategies have been developed over the years, I should say. And it's funny, when I was preparing for this talk, to think about that I've been involved in all of them. So I still like to think of myself as a new kid on the block, but I'm not. I'm turning into one of the I was going to say fossils. Maybe that is the right word to use. You can judge for yourself. So, of course, there's the national policy and strategy for the provision of neuro rehab services, then the rehabilitation model of care, and the implementation group that was put together to implement the national strategy and policy. And you can think to yourself, how well are we doing on the implementation front? I have my own views. I'm sure you will have yours as well, and I'd be very surprised if they were different. And from a spinal injury point of view, there's the National Clinical Programme for Neurology, and of course the trauma system for Ireland. Although, again, I was refreshing my memory about these documents and preparing for this chat today, and the need for us to be thinking about all health conditions, I guess, within the context of the ICF model, and that is a cradle to grave concept is not terribly evident in these documents. Although, in fairness, the trauma system report does make reference quite a lot to the rehabilitation medicine model of care. So that's something. And the integrated care programs were developed in response to learning that came through over the course of our work in the clinical program. So we recognise the need for us to be more integrated in our approaches, to be really thinking about unintended consequences. And we really did learn a huge amount, but really standing on the shoulders of giants, if you like. We learned from the work that had gone before in the development of the integrated care programs. And in terms of the evidence of taking a joined up approach to the provision of services, I'm not sure if you'll have come across this paper, because it's only just been published, I think it might be 2 weeks ago now, but it's very interesting. So it's using the UK ROC database, but they specifically looked at functional outcomes and cost efficiency of specialist inpatient rehab following spinal cord injury. So if you haven't had a chance to read that, have a read. And no surprises that, it does make a difference. So when you as an individual with a spinal cord injury have access to the services that you require, it does save money for the exchequer, and it does result in better outcomes for individuals and their families. And then, of course, there is the integrated care pathway for the management of spinal cord injury that was developed by the clinical programme for rehabilitation medicine. And again, it is a nice document full of good advice. The issue that we have in Ireland is it's a really pathological difficulty with implementing things, most things, and this has been around now for quite some time. And yes, there has been progress, but are we satisfied that every individual that sustains a spinal cord injury has access to the right care at the right time by the right team across that continuum of care? ... And you're far better positioned to answer that question than I. But once again, I think you and I might have similar ideas to where we think we're at. So I hear you ask, Anya, what is all this integrated care stuff? So what I'd like to do next is really reflect on that, because I think it's wonderful that we're hearing such a lot about integrated care, but it does make me smile because it's a bit like rehabilitation. It's one of those terms that people are talking a lot about, but my observation is that we are talking about completely different things. So is it important that we have a shared understanding about what we mean? Yes, it is really, really important, because it is not, so, you know, integrated care and rehabilitation are not the same thing depending on the people that you're having a conversation with. So it's important to get these things right. Words do matter. So there was Dennis Kodner in 2009. So Dennis was a fantastic thinker in the whole area of integrated care. He was one of the original board members for the International Foundation for Integrated Care, but a great thinker, and has published lots of really great stuff on integrated care. But this was really a seminal piece that he wrote. So basically, he described integrated care as a concept that is an imprecise hodgepodge. Its meanings are as diverse as the numerous actors involved. And what I was trying to say to you there a minute ago was, like, it is like that cartoon there. It really depends on who you ask. So having a shared understanding in Ireland or within our regions about what do we mean by integrated care is really important, because otherwise, how will we know if we've got there? So we took the rather unusual step in the HSE of deciding that actually, rather than us plucking a random definition out of the air, that we would actually ask patients what their vision was for person-centred integrated care. And this was a piece of work that was done in the patient narrative project, Your Voice Matters. And I would be forever grateful to colleagues in IPOSI and UCD for doing what I still think is a really, really important piece of work. And I wish that we could see it a lot more in all these discussions that we're having at the moment about sláinte care. I wish we could see it more in every single piece of policy and strategy that comes out of either the HSE or the Department of Health. Because to my mind, if your piece of work or your report or your strategy does not speak to this definition of person-centred coordinated care, then it shouldn't be done. So, Anya, I hear you crying. What is the definition? So, Irish patients have told us that they want person-centred coordinated care that will provide me with access to and continuity in the services I need when and where I need them. It is underpinned by a comprehensive assessment of my life and my world, together with the information and support I need. It demonstrates respect for my preferences, building care around me and those involved in my care. So when you initially look at that definition, you kind of think, yeah, but when you really look at it, and I've underlined the key things that I think are really important, then have a look at that and think, how are we doing? ... So I'll leave that with you. And if you're interested in reading more about that, we have published it at the beginning of this year in the International Journal for Integrated Care. And it will go into a lot of detail of, this is very much a summary slide, a lot more information. And also, of course, on the IPOSI website. And once again, sincere appreciation for colleagues in IPOSI and in particular Amanda Phelan and colleagues in UCD. So the International Foundation for Integrated Care have been working for many years about what are the building blocks of integrated care. And when COVID hit last year, colleagues in IFIC brought together key thinkers in the world of integrated care, of which I was one, imposter syndrome. And we really reflected on our experiences on the literature and our understanding of what are the really necessary things for successful integrated care. So we have produced a document. You'll find it on the IFIC website, and it shows the 9 pillars for integrated care. So first is shared values and vision, population health and local context, people as partners in care, resilient communities and new alliances, workforce capacity and capability, system-wide governance and leadership, digital solutions, aligned payment systems, and transparency of progress, results and impact. And again, if you're interested, please read the vision document. But what I would like to say to you is it's really important that we don't look at these pillars as silos. It's really important that we see these as really shifting, dynamic, changing things that interact with one another, because sometimes you'll have strengths in some areas and weaknesses in others, but that will change. And if you think about the current discussions about the restructuring that are happening, you can see how that restructuring might seriously impact on some but not all of these. So how you really need to be constantly attending to these 9 pillars, but appreciating that the dynamic nature of the interactions between them. So when we were setting up the integrated care programs, we didn't just pluck a notion out of Anya's head. We did try to be as evidence informed as we could be. So we commissioned 6 literature reviews, and you can find those literature reviews still on the Clinical Strategy and Programs website, although that's now called the Clinical Design and Innovation. And we also undertook 4 participatory workshops. So the overall vision was that we would be providing person-centred, coordinated, co-designed care. And we identified 4 integrated care programs: prevention and management of chronic disease, patient flow, older persons and children. And even over the course of the development and identification of those 4, that really changed. I was very keen that we would have a maternal health and children's health programs. But events really, it just shows you how quickly things can change. Things following on from the Savita Halapanova report, they set up the maternal office. And I felt that there was going to be confusion around who was doing what. So we just said there's no point in us pursuing an integrated care program for maternal health. And I think that was a real shame, because we really should be looking at integrated care for maternal health. Anyway, so this is my regrets. I've had a few, but at the same time, one has to be quite pragmatic, and there's no point. This is already a very complex task. Things could very easily have been turned into quite a conflict situation, and sometimes you have to just pause and think, maybe just pause that and come back in a period of time when things are more receptive for the idea of thinking quite differently. So where are we? And it was interesting, again, when I was preparing for this, that I was thinking back, so how do I know where we've got to? But actually, we have done quite a bit of work over the last number of years. So phase 2 of the Your Voice Matters was a sense-making exercise. And unfortunately, I won't have time to go through what that means. But it, again, very nice project. I nearly finished writing it up, which will be open access. So if you're interested, the SII might keep you posted when it gets published. Hopefully it will be. Then we looked at the barriers and facilitators to the implementation of the clinical programs, and we used the MRC framework for process evaluations. Why is that important? It is important because we need to get better at figuring out how do we study these complex interventions in complex adaptive systems. That's my current obsession, by the way. And we need to be testing different approaches. So MRC is one way. And interestingly, they just published last Friday the updated MRC2 framework for process evaluations. They have definitely given a nod to complexity theory. I would have liked to have seen a lot more of that. But then that's because I'm complexity obsessed. So, but I'm dying to test it out. And then we also looked at the assessing practice and preparedness for integrated care delivery. And we used, again, it's all evidence informed, and we used the Project Integrate framework that was developed in a very large European project. And then we also did a qualitative study of acute hospitals. We used mixed methods evaluation of the implementation of reconfiguration and the impact of that in Ireland's hospitals. We did an evaluation of the implementation of the National Clinical Programme for Diabetes. And currently I'm involved in using case study research approach to evaluation of a regional palliative care service. And that thinking is at the forefront of global thinking in how we look at complex interventions in complex adaptive systems. So there are good ways of doing this. Ireland should be stepping up to the plate and really getting immersed in these really rich ways of understanding how we evaluate and design and deliver programs of care. So just a quick summary of some of these findings. So your voice matters, the recommendations and the key areas for improvement were, and there'll be no surprises to you, there needed to be clear communication and information. Needs to be collaboration and partnership working between service users and staff. There needs to be coordination of and access to services. So no big surprises there, but at least we know it's there. We know that we need to improve those things. The MRC framework and the challenges that were identified were the need for leadership governance and clinical networks, the need for social and understanding of the social and political context, the need for resources, identified resistance to change, the need for really good quality data and information systems, and the need to change the model of care. So you already see some common themes weaving through these different evaluations. And then we also, this is using the Project Integrate framework and tool. So again, I don't have time to go into a lot of detail, but we used the rainbow model. Okay, the rainbow model, I like it because it's nice and colourful, but it was a really nice piece of work that was done by a colleague, Pim Valentine, for his PhD. But I think it's a very nice summary of all the domains that you need to be thinking about when you're thinking about integrated care. So basically this was in the research that we did, it was a large project that involved a lot of people, of service users, clinicians, managers around the country. And basically, essentially, these are very high aggregate results. But like our 5-point scale, and as you can see, the highest we scored was 2. So the general feeling was that the kind of the person-centered was probably our best, and professional integration was our best. But you can see that it was very clear that we had lots more work to do in all of those areas. And the recommendation from that piece of work was that national cultures, policies and structures, we need to enable and lead innovation and change. There's a need for ICT and e-health and really good management and HR processes. So again, you can see those common threads coming through all of these pieces of work. And that idea of innovation and the creation of that adaptive space whereby you can safely test innovations, and if they work, that you can make sure that they get spread quickly around the country so that everybody that could benefit from them can get access to it, is a major challenge. And of course, where ICT issues are the stuff of legend at this stage. So if you think about the principles for integrated care programs, and then within the context of spinal cord injury, it's quite interesting. So is it a disease or condition that currently affects significant population cohorts? Yes. Has there the significant potential to reduce the burden of illness? Yes. Significant potential to alleviate service pressure points, waiting lists, delays? Yes. Members of vulnerable groups? Yes. Outputs will result in appropriate care delivered in the appropriate setting at the appropriate level of acuity. Yes. Implementation of the model will result in improved quality of care. Yes. Considered appropriate by patient advocacy representatives. Yes. Potential to obtain value for money. Yes. Services delivered by at least 3 operating divisions. Yes. The programme would require multidisciplinary care planning. Yes. Benefits would be tangible and measurable. Yes. So if you like, spinal cord injury lends itself to an integrated care programme. And interestingly, when I was preparing again, I went and did it now desktop review, but I wanted to look at research specifically looking at integrated care and spinal cord injury. And there isn't any. So I was really surprised. Now, again, it was not a comprehensive literature search, but very often when I'm curious and I just jump in, and I'm very fortunate having access to the university library, jump in and have a look, I couldn't find any. So if I were you, I'd be thinking about that. I'm thinking about how might we seek to address that big gap. So I thought that was really interesting. That was very unexpected. I thought I would be able to share with you what I had found, but I couldn't find anything. ... So all this talk about, shift left, stay left, and this is Martin Curley's slide, and I quite like it again because it's colourful. But this notion that we need to move away from a hospital obsession towards that shift in power, and I like that. So this shift left to me is about a shift in power to patients and individuals in the community, and I think that's really important and really necessary. It should be all about community first, not our current complete obsession with hospitals. And again, it was interesting to reflect back on, so I always have to think about what age my son is. So 17 years, lads, since I moved to Dublin. And it's been a busy time, a very busy time from a healthcare policy point of view. And sincere thanks to Sarah Burke and colleagues who actually have done this work. I have, as quality improvement methodology taught me, steal shamelessly, but I must acknowledge the work of Sarah and her colleagues in doing this timeline. But hasn't it been busy? Hasn't it been busy? And yet we have to ask ourselves, how much has been implemented? ... So the latest thing, of course, has been Sláinte Care. So the Sláinte Care report itself and the implementation plans and the action plans. And there was a new action plan which was announced just before the 2 high-profile resignations happened. So I thought I would have a little look at the Sláinte Care Integration Fund project. So I had a good look, and I looked for projects to do with spinal injury, and there were none. And again, I was really surprised by that. And I can't give you the answer to why that is the case, but there aren't any looking at persons with spinal cord injury. And I thought that was interesting. Why is that? I don't know, but there weren't any. And especially when the goal of Sláinte Care is to deliver or to enable right care, right place, right time by the right team, which takes us back to a previous slide that I was talking about. And that they aim to achieve that through population-based approaches, clear pathways, empowerment of frontline staff, and the idea of one budget per region. So spinal injuries really need to be part of that conversation. I would have thought, and I suppose the key thing is, how do you do that? And it's not easy. It's not straightforward. But perhaps now is a really good opportunity, when there's a big major rethink going on, that you think about, so how are we part of that conversation? Because when we look at the organograms, and it looks lovely, and here we've got, it's all very clear. We know what we're doing because we have a clear organogram. And so there's the governance that was envisaged for the new structures within the health service. And this is within the HSE, and it's all ordered, and it looks, when you look at this type of an organogram, you think, yes, they know what they're doing because there's a clear organogram. But of course, unfortunately, life isn't like that. This is much more what healthcare looks like. And I'm very grateful to my colleague Geoffrey Braithwaite from Macquarie University. And if you've never heard Geoffrey talk, well worth inviting him to speak, because he's a gas character altogether, but has got very serious things to say. So we imagine that that's what healthcare looks like, when actually healthcare looks like this. It's messy, it's unpredictable. And then if you think about, and if I think about my, especially when my father was ill, he passed away in January 2019, diagnosed with cancer, 6-month journey after diagnosis. And how fragmented his services were, how it really was, and as, if you like, the chief navigator of that journey, it was immensely difficult. The unnecessary complexity of it is something that still makes me catch my breath. It does not have to be this way. It should not be this way. We are still not person-centered. We are discipline-centered or organizationally centered. We are not person-centered, and that has got to change. So I'm going to give you my tuppence worth, and these are my reflections on, I suppose, it's going to be 30 years since I qualified next year. Yes, I know you're shocked and you're stunned and you can't believe that I could possibly be that age, but it's true. So I'm going to give you my tuppence worth. So my belief is, and I know this to be true, that we need to be viewing healthcare as a complex adaptive system. And I don't have time to go into what that means, but essentially a complex adaptive system is a system whereby agents, in our case human beings, interact with one another. And by virtue of those interactions, something very magical can happen, or not, as the case may be. So it is, and the key is that rich connectivity, and in figuring out how we respond to some of these challenges. So, and I know the idea of micro, meso, macro, but micro is, if you like, that close to the patient. Meso is that kind of either organization or region, and then macro is really at policy level, so kind of HSE, top echelons, and Department of Health. So at the micro level, it has to be about the patient as a partner. I think that is really, really important. And what matters to you as an individual, rather than what we think matters to you. It is about frontline multidisciplinary teams making local improvements. It's about clear ways of working and support for changes, because our frontline staff are full of the most extraordinary ideas for change, for improving things. And we should be completely obsessed with just helping them to make those changes. But very often it's just so hard. And that fire over many years just gradually diminishes. And I think we just have to make sure that we don't, through our process and bureaucracy, snuff out that wonderful fire. We need to be fanning it and really nurturing it and allowing it to not just burn, but to actually to be an inferno. And then lastly, from a micro point of view, that we have got clear pathways of care developed nationally, but that still allows for that local interpretation. That's very important. So at meso level, that is about the community healthcare organisations and hospital groups, or the new RICOs that are coming down the line, working together. And I've learned a lot from the differences between different countries and cultures and different health systems. In Ireland, that requires laying out clear frameworks. That means having memoranda of understandings, or as people often talk to me about, I'm not doing anything until I get the letter with the harp. So sometimes you need to get the letter with the harp. Although in other countries, it is simply about people coming together and agreeing to work together differently, agreeing to share budgets. But in Ireland, we do like our letters, we like our frameworks, we like our steering groups, we like our working groups, we like our documents to track progress. And I think that just a huge amount of time and effort gets expended in things that don't matter, frankly. But hey, you have to figure out what's going to work in your local area. There does need to be clear governance, and it took me a long time to appreciate that. I used to think that a lot of it was unnecessary bureaucracy, but actually a level of governance. You do need to know who are the decision makers, how do things work, and being able to identify people who can actually remove barriers or give you seed funding. You do need to have that. You need to know that. And we do need resources. So not a lot. My experience, people did not look for a lot of resources, and in some cases it was just a tiny amount of seed funding that was required. But then in other areas there are clearly not enough resources, and sometimes you just need to address those, because you can't do something with nothing. Then at macro level, you need that leadership from the top. So from those top levels of the HSE and the Department of Health, they should be there as enablers and facilitators and people that help support the work of the front line. I come back to that idea of clear governance, because to my mind, you need to know who are the people that can take those barriers out of the way. Who are the people that can give you some money to do the things that you want to do? There needs to be a monitoring of benefits. We are not very good in Ireland at carrying out proper, robust evaluations. We're really not. And the idea of just summative evaluations is really so last decade. We need to be thinking about formative evaluations. We need to be thinking about developmental evaluations. And we need to be setting aside 10% of any budget for any new initiative needs to be set aside for evaluation. That's what they're doing in the rest of the world. We always think about evaluation. Oh, jeepers, we're now 3 years into the project. I guess we need to be doing some kind of an evaluation. And then it's not that learning experience that could really help to inform the project over the course of the project, and then also to provide learning for other teams and other organisations. So I believe that the leadership are there to enable and facilitate, and frankly, get out of the way. Enable, facilitate, but otherwise get out of the way. So I think what I'm saying to you is that it is all about partnership. It is about a partnership with patients, families and carers, clinicians, managers, policymakers, researchers and academics, public and private, the third sector organisations, working together with statutory organisations, and also training bodies. So we don't get these people together enough to be figuring out how to fix some of this stuff. And really that's what we're very passionate about in the International Foundation for Integrated Care. So IFIC is a not-for-profit organisation that inspires, influences and facilitates the adoption of integrated care in policy and practice around the world. And it's our vision that people, families and communities benefit from person-centred integrated care and support to maximise their health, well-being and independence. And we have established the IFIC Ireland hub, and basically it was originally founded between UCD and IFIC. And we have myself and Fiona Lyne, Fiona's here, as co-directors, and our chair is Dr. Sloane Harper. And Sloane was the Director of Integrated Care Partnerships in the North. who had recently retired but has gone back into full-time work as an advisor to the Health and Social Care Board of Northern Ireland. We're very fortunate to have his wisdom. And we have our steering group, and we're very grateful to have as our patient partner Jackie Brown, and many of you will know Jackie. She is a very vital contributor of the need for us to have the input from patient partners into the work that we're doing. And we're very, very glad to have her wisdom and expertise. We have a number of different knowledge partners, and of course the people that really make things happen. And we're very fortunate to have Karen and Darren. Darren is on sabbatical at the moment, but they keep the show on the road. And if Spinal Injuries Ireland are interested in becoming knowledge partners, we would be absolutely delighted. This is not an exclusive organisation. If you're interested in integrated care, then please do get involved. If you're interested, then we're kindred spirits, and we want to work with you. So we've been up to all sorts of different things over the last couple of years, and for 2021, we've been up to all sorts of things, knowledge mobilisation activities. We're involved in European projects. The Value Care Project, for example, is looking at digital supports for individuals in Cork and Kerry, supports to live independently in the community. And we're doing that case study research evaluation, as I told you. We work very closely with the other IFIC hubs, and we also work closely with the special interest group that exists within IFIC, and you can get access to all of those through the website. We're exploring this year using an echo approach, and from a spinal injuries point of view, that might be something that you might like to think about. And again, we can talk about this another time. Leadership development, and we have a very active operations and communications. So, we have much done, more to do, but it is about generating that sense of urgency and excitement around the possibilities of integrated care. And that's what excites me, and things that just have a ripple right out in not just our own country, but beyond. It's so very exciting. We have a knowledge tree, and the knowledge tree was supported by grant support from Sláintecare, which we were very grateful. And really, this is a gateway to all sorts of different types of information. So if you want to know anything about integrated care, you'll get access to best practice, case studies, publications, all sorts of interesting things. So check that out. And that was quite a bit of work in terms of pulling there's such rich information and data available on integrated care, and Karen and colleagues pulled that all together, and this is just a little snapshot about how those artifacts were gathered. So there's a lot out there, and what we wanted to do was to try and translate all that stuff into something that would make it very easy for people to be able to find what they were looking for. So do check that out, and I hope you find it useful. So basically, IFIC Ireland are launched, and we are ready to serve. And if we can be of any help and support to Spinal Injuries Ireland, or if Spinal Injuries Ireland want to join us as a knowledge partner, we would be absolutely delighted to welcome you, and we would welcome you with open arms. So I wish you every success in your conference. I hope I have piqued your interest. And if you wish to contact me, please contact me. My email address is there. If you want to contact Karen in IFIC Ireland, our contact details are there. So it has been a pleasure sharing my thoughts with you, and I look forward to having a chat and taking any questions that you might have. So thank you very much indeed.